So downstream effects again, with the electronic health record, making sure that we have that integration and dependence, and that's a good thing that we have that integration and dependence. But we it becomes very impactful when we don't know what to do when that's not available anymore. Um, I recall a provider when we transitioned to an electronic health record, and he sat down and he was working with the in the transition period, he was helping to cover at a hospital that still had paper, and this was probably about 10 years ago. And he sat down, he's like, I don't want to go back. He goes, I forgot what it was like to have to go search for a chart, to go find where the lab was, where this was. And during the downtime, that some of that is, we need to make that smooth, but we do kind of take a step back in time when we're doing that. And so that downtime preparation really becomes important. And then for staff and patient, we want to make sure that we're not negatively impacting our patient outcomes, that our staff are still satisfied, that we're able to take care of them, and that we're able to utilize all of the resources. And of course, there's stress involved, those downstream effects, not just with the staff that's working on the floors with the patients, but also the IT staff that's trying to do their best to get everything up and running and ready to go and take care of what they have. So lots of stuff going on, and we're hoping that we can try to make that all a little bit better. So our experience and our evolution. We started, and I can't even recall the exact. It was probably about 5 years ago. Major downtime. There was a cable that was accidentally cut when they were doing some construction. It was on one site, but that site was down for about 36 hours. That really kind of got us and opened our eyes up as far as working through the policies, the processes, and making sure we were really set for what to do during a downtime. Um, we have a big um, area that we cover over 4 states, but this, even if it's only one site, it really took we really tried to focus on our inpatient staff first. So our policies and processes, we really kind of honed in on them, made sure that they were taking care of those staff. They're here 24/7, and really looking at what to do, how to do that. Our policy also included actually handwriting examples, because as everybody's seen right now, we have staff that have never charted in paper before. So a lot of the newer staff, the newer nursing grads, they've never charted in paper, and they weren't quite ready for that. So we had to kind of show them how to do that. And we've talked to our leaders also, and we continue to grow this. We had a great foundation set when they developed this policy and process. Um, about a year ago, we had a system downtime in the middle of the day. It was about an hour. Um, it highlighted for us something a lot of us already knew, but we had huge ambulatory gaps. Staff didn't know what to do during a downtime. They didn't know where to go. There was panic. I think it was even during a lunch hour, but it was like, what do we do next? How do we get there? That really helped us highlight those ambulatory gaps and start to bring those folks into the conversation so that we could start to make things a little bit better. Knowing that, we had found out or discovered that we had these downtime workstations in some of our clinic areas, and in some of them didn't have it. But we really needed to do an overhaul. So in Wisconsin, what we ended up doing was we sat with them first, and we had one of our systems had about 250 workstations that we needed to identify. And so before we started anything, we had our desktop team. We worked really carefully with them and closely, and we identified where those downtime workstations should be. Kind of set up some guidelines, talked with the staff. They actually went to each site individually, worked with them, showed them where they would probably be. We had some staff or departments that had maybe an overload. They maybe had 5 workstations, and they really didn't need them. They maybe needed two, one for registration and one for the clinical staff. And so we had to talk to them and explain to them why they only needed two. And we wanted to keep our maintenance down, and not only for us, but for them to not have to test. So we had to explain all of that and get that going. It took us probably about 8 months, I think, to make it through all of those departments, kind of shore up our downtime workstations and where they should be. And by May of 2022, we were finally ready. What we did was we developed an electronic test. We work in Epic, but we used the testing functionality that they already have to when they start new testing for technical things like printers. And so we utilized what was already in there, and we tried to make it beneficial and workable for our clinical staff. And we were really kind of pleasantly surprised that it worked as well as it did. That there were a few things that they had to do, but they really kind of jumped on this a little bit and really started to take over. And we got a lot of positive comments. By fall of 2022, we rolled this out with the rest of the sites. Um, the one thing that we didn't do was in the other regions, we did not really focus on preparing all the workstations. And so instead, we wanted to get the testing rolled out. And then as we were doing it, we were finding which workstations needed to be cleaned up or changed, or just the functionality made better, and check those locations. So we did that all kind of simultaneously by fall. And I will show you our results, but we did really well at getting everything processed. And then by March of 2023, we decided that we were going to start a dashboard. Previous to that, we had been creating a dashboard that was a manual one, and every day during our periods, we would share that out to get the interest going, and just keep the energy behind it. But we felt it was now time to use the automatic dashboards that were there, and so we will talk a little bit more about that as we move forward. So that's kind of our timeline as to what we've all done as we've gone through, and I will show you some details now. So I'm going to take a step back. Our first major our manual process that we use was paper testing forms. We utilized multiple versions. I think there were 4 versions of the paper forms. We had to make sure that we got them out. If there were any revisions, we got those paper forms back out to whoever was utilizing them. They would test with those forms. Once they were done, they would scan the form to a site, whether it was somebody in their region or a centralized site. Those scanned forms were then uploaded to a SharePoint site so we could keep track of them. And then we also took those testing details and we added them to an Excel sheet so that we could tell what our percentages were, where we were with everything. We tested monthly at that time. When we went through that, what we found was we had a lot of paper and storage issues, just keeping up. If we change anything, we had to get that back to them. There was a lot of testing time, a lot of testing time that was utilized, and it was a little bit. It was some of it was with operations, but a lot of it was on the back end with us trying to collate and pull all those results together. We also had the scanning time. We had to troubleshoot. We had to have somebody available if maybe their scanner wasn't working, or sometimes they thought they scanned and they didn't, that kind of stuff. And so we really kind of worked through that. And then we had to maintain that SharePoint, and we were really, really dependent on staff to report issues. Um, and we use a ticketing system, so we would ask them to help us and to reach out to us if there were any issues out there. So we depended upon that. Um, a lot of that, we worked through that. It was just really, really helpful for us to just take that step back, really look at that process, and then build off of it. So our electronic process. What we are really looking at now is a lot of time and resource savings with the electronic process. We now include our ambulatory areas. We are still working on those areas, as some of them have developed. Everybody has a different communication. Um, Kind of communication tree, distribution list, however they communicate out. So we're really working with them and trying to both understand what their communications are, but also trying to create a standardized communication.